Prevention and I'll start again. This is our Center for Suicide Prevention and Recovery Spotlight Talk, where we present research and other innovative programs that have been developed either internally from our center or one of our colleagues here at the University of Washington, or like today, when we know of innovations in treatment and suicide care from other places like University of Alabama with Jennifer here today. So these always happen on the third Thursday from 9 to 10 Pacific, noon to 1 on the Eastern time zone. And I'm Kate Contois. I'm the director for the center. So today we're going to be hearing from Dr. Jennifer Lockman, who's an assistant professor at the University of Alabama at Birmingham in the Department of Psychiatry and Behavioral Neurobiology. She holds academic appointments in the Depression and Suicide Center and the Center for Clinical and Translational Science. Dr. Lockman's a psychologist and clinical suicidologist and completed her doctoral and postdoctoral academic training at Purdue University, the Vision II Center for Excellence for Suicide Prevention, and the University of Rochester Center for the Study and Prevention of Suicide. We all have different order of letters in our center names. At the University of Alabama, Dr. Lockman's research lab focuses on studying suicide recovery, including novel recovery-focused interventions for emergency department, inpatient psychiatry, care transitions, and outpatient care. She also leads an active clinic at the University of Alabama, Birmingham, where she instructs residents and psychology interns in the delivery of compassionate, recovery-focused care for persons with suicidal experiences. Her work offers a paradigm shift in suicidology toward transforming everyday clinical practices by putting recovery into the center of everything they do. Thank you so much for coming and presenting today, Jennifer, and I'll hand it over to you.
Definitely. Well, thank you so much for the invitation to come, and I'm so excited to be among so many people today that are doing academic work in this area and related areas, and also perhaps some practice partners. The more I do this work, the more I realize we need all of us, and we need all of us thinking together on these things, sharing information as soon as we can, and using that to innovate and iterate better care practices. We are certainly not arrived yet at what best practices can be, and so I hope we're all on that journey together. So I'm going to go ahead and share my screen with the slides for this presentation. We'll definitely be saving information sometime at the end for questions, and would really welcome a dialogue around this information. So, okay, everyone seeing my screen okay? See some nods. All right, so these are my disclosures in terms of current funding for my research program, and definite thank yous to the American Foundation for Suicide Prevention and the National Institute of Mental Health. I'm also the intellectual property holder for the Thrive, previously called Relate interventions, that I'm going to be sharing about today. I also wanted to give credit and thank yous to our Thrive collaborators. We have so many people in community mental health and industry and academia who are collaborators and co-scientists on this work, and very, very thankful for the partnerships that exist there. So just a little bit about me, because the more I do this work, the more I realize that understanding our reference points may matter quite a bit. I am a counseling psychologist and suicidologist by training. I'm an assistant professor here at UAB, and I really have two roles. I'm primarily research. I spend about 70% of my time right now doing research, and 30% of my time I lead an active clinic at UAB, and also train residents and psychologists and supervise them in our clinic. I'm very, very excited that we have a strong mission today around delivering all of the care that we know that works today, while innovating and iterating the care for tomorrow through research. And so in our clinic, we do offer all of the mainstream psychological treatments for suicide that are evidence-based that many of you all are familiar with, CAM psychotherapy, BCBT, DBT, several others. And so we are very excited to be learning in a very active way, just having resources to say, we're going to give you everything that we know that works today, but also finding new things about how to implement that in the real world, what works, what doesn't, and for whom, and also what new things might be needed when people are not treatment responsive to the best that we have today. It doesn't work for them. And we want to make sure that everyone has a pathway to not only staying safe from suicide, but really building a life that they can live and want to live and to self-identify as thriving. So very thankful for that work. And do the work at UAB with wonderful colleagues and very thankful for that. So let's start our talk today with thinking a little bit about suicide recovery and this being an emerging frontier, especially around suicidology research and practice. We know, from the literature and from conversation with people that just to kind of take a historical walk down memory lane, that suicide definitely continues to be a public health concern. In this audience today, I don't think anyone would, have any qualms with me saying that. And in clinical suicidology, we've done a lot. There have been a lot of major advancements that have happened in our field. We have certainly tried to develop predictive clinical risk assessments for suicide. We know that risk prediction is not something that we're able to do today. And we're still working on what does that mean in terms of what do we do next. Certainly there have been advancements in theories about why people die by suicide that have been very transformative in terms of how we deliver care. We've established effective psychological treatments that reduce suicidal behavior, but don't always reduce the desire to die. And that's, in my opinion, a critical challenge. And Dave Jobs and several others have pointed this out, but we can only track people in research for so long before the study ends. And even if behaviors are mitigated for a certain period of time, which is good, we want people to be alive and well. If we don't change the fundamental desire for death, we know that suicide risk increases across the lifespan. So so we don't know for sure. We need more research in this area, but it's very possible that if the desire to die is still strong, we may still see suicidal behaviors 5 years, 10 years when that person hits their 40s. If that doesn't change. And so it is a critical challenge and one that I think we need to continue addressing in our treatments. And then, my perspective is that understanding when and how to intentionally help people not only stay safe from suicidal experiences and behaviors, but help them truly recover and grow from those experiences may allow us to improve care. If we are able to instill that the value in treatment for suicide risk is that our goal is full recovery in terms of what that means for that person. And to know that they, not only haven't had suicidal behaviors, but they don't want to die anymore. And they don't have suicidal suffering anymore. I think that is an opportunity for us to say, how do we get there? How do we get there for each person every time? Because it's certainly a shared goal. I think it's always been a shared goal in our field, but it's one that I would say we're still working on and we can still grow in. And so with that background, I'll add to that most of what we know about suicide recovery is qualitative at this point. There have been several qualitative articles talking about the endpoint of suicide recovery in terms of what it means to people to have recovered. What do they identify as recovery? And I think that work has been really critical. I also do qualitative research and very much value it. And at the same time, a lot of the themes, if you look at the themes in qualitative research, it maps on to very much to existing larger frameworks around recovery from mental illness. And on the one hand, that's not bad at all. It means that elements of recovery for people with lived experiences of suicide are not altogether different than recovery from other forms of mental illness. And at the same time, I think when we talk with people and colleagues and patients and people in our research studies that have lived experiences of suicide and also experiences of other recovery, such as from addiction, they say it's different. They say there are different and unique elements of recovering from suicide that are different from any other type of recovery. And so a lot of the work in my lab has sort of focusing on, through several different studies ongoing right now, what are those things? What are those unique things? How do we define them, measure them? Not just the endpoint of people who have recovered, but the actual overarching processes that help people get there and help them get there sooner and maintain that recovery. So we could do a whole other talk on that. What is recovery? But today we're going to talk about Thrive. And so definitely invite more conversation and questions about that. So at the time that I was starting to really study suicide recovery, what that means for people, where do we go next with baking this into our treatments, perhaps, and when and for whom, I was connected to several crisis stabilization centers that are very recovery focused, which was just a very wonderful blessing and opportune moment. For those of you who might not know about crisis stabilization centers, crisis stabilization centers are community-based centers that are being stood up very rapidly across the country. Crisis stabilization centers are called CSCs or CSUs. They go by many different names. They're typically, for the most part, there's some exceptions. For the most part, they are fairly small. They have, less than 20 beds in most places, but they have very rapid turnover. Many places have a kind of quick admit and discharge unit called like a 23-hour observation unit so that you can get people rapid care and discharge them back into the community safely. Other places also have overnight stays in unlocked spaces with like a living room look and feel, but also that's very physically safe from suicide in terms of ligature points as a hospital would be. And so they have that option for people to stay on average 1 to 3 days and then discharge safely back to the community from what we know today. And then also some places are what we call high acuity CSCs, and they do have locked wards, just like an inpatient facility would have. But I would say that the culture is very different from a traditional medical model, depending on where you go. And they are very recovery focused. It's baked into their philosophies in ways that were amazing to me when I first started visiting with and working with these wonderful practitioners in our community. And people go to crisis receiving centers from several different places. They might be transferred directly from ED via public transport or ambulance, and this would be considered a lower level of care instead of admission. They may come by police drop-off by people in the community to say, this person needs mental health care. Let's make sure to get them to a mental health facility, and they can come in that way. And all these places also have self-walk-in, so self-admit. You can come in, walk in, and talk to somebody and stay. There's also a lot of peer support specialists here, and they are serviced by interdisciplinary teams, absolutely a treating psychiatrist, nurse practitioner. Many have mental health counselors or social workers, and peer support in terms of hiring and strategically training people with lived experience is a huge part of the recovery philosophy in these spaces and is different than how hospitals traditionally, I would say, operate and maybe still operate today. So these are wonderful receiving centers. And as we know that as 988 is increasing and call volume is increasing, which this shows, more and more people are going to need places to go to be able to stay safe from suicide, but hopefully also jumpstart their recovery process. And that's something that we're going to be talking about today. And so there's right now a lot of advocacy, funding, being invested in standing up these centers across the country, because we know, as you all do, emergency rooms are already flooded. They may or may not have people well trained there to deliver suicide care. And we want to make sure that people get the right interventions each time and every time to truly get better for what their needs are. And this may help fill that gap. And yet, we could talk more, but there's very, very, very little research on crisis stabilization centers. Very much lacking in longitudinal data. We don't quite know how people do post-discharge follow-up compared to ED or inpatient follow-up, for example. And there's a lot to be learned about what works for whom and in and around these facilities in this culture. So in the process of setting up this research program, being very excited about suicide recovery, starting to do work on interventions in this space, I was contacted by a colleague, Adam Graham, who is working in a crisis stabilization center in Nashville that many of you might know, and he's at TBD Solutions. But he calls me and he's a friend and colleague, and he asked me this provocative question, as Adam does. He's like, Jennifer, what would you do if you had 1 hour to help create a turning point from death and dying to life and living? And I'm like, that's a big question, Adam. I have a little bit of time to think about that. He said, sure. He's like, but we're thinking about it here. And Adam's an innovator, and he's very passionate about treatment, has had wonderful support at the time from Mental Health Cooperative where he was working, and that we're still doing research and from their leadership. And it was a question, and I had to really think about it. because it's such a short amount of time. But as we decided to meet about it and talk more, we started to think about in these spaces, what would a brief intervention look like? And their sense was, from a community-based standpoint, that crisis stabilization center or CSC interventions needed to have a couple of qualities. They needed to be ultra brief. They needed to be able to be delivered to individuals with suicidal ideation and or attempts, because most people in these facilities are presenting more with ideation, but a history of attempts, not an immediate or recent one within the last couple of days. Um, it needs to be deployable to individuals who are not yet willing to stay safe. And we know from emergency departments that's also a challenge there with doing safety plans, for example. So that's, they're seeing a very broad spectrum of suicidal presentations, and that was important. This needs to be accessible to everybody. Able to be delivered in multidisciplinary teams, easy to learn and fast and very cost effective. There's high turnover environments in all of community mental health right now. And centered on recovery, which we had large conversations about what that would mean. Restorative in terms of repairing broken trust with possibly prior counseling experiences or professional care systems, with outcomes focused on self-motivation for recovery and treatment initiation, and also able to address the why stay safe. They were already doing safety plans with everybody, and their sense, this Stanley Brown safety plan there, and their sense was for people who are ready and willing to use it and want to stay safe, it works fine. But you have to know why you're using it. Like, why address like your warning signs if you're not sure why you want to stay safe or if you want to stay alive. And so we had these wonderful collaborative conversations, and we reached this core decision point, as we all do, in terms of, well, do we adapt an existing intervention? Do we deploy an existing intervention with new implementation strategies, or do we innovate and create something new? And I could show you the charts and whiteboards. We went through this process together, because I'm such a proponent of, like, please let's not build something new. If we can, adapt, modify, or, utilize new implementation strategies, because as we know in research, these things take decades to build and do well. And I have so much respect for all the existing interventions that we have that seem to work with the populations that we have studied them in. And at the end of the day, we decided to build. The center was we talked about, we dissected several existing interventions. We looked at CAMS, DBT, had conversations about, well, if we just start a piece of something, maybe they'd be more likely to continue it in the community. Could we give them longer care? And their sense is that recovery needs to be upfront and center. It needs to be the focus of the intervention. And we had a lot of conversation about that, because there is some research suggesting that an overinflation of hope in an index point of crisis may exacerbate suicide risk. And we had some concern about that. We didn't certainly want to make the problem worse or people suffering worse, but yet they were convinced, and I appreciate their fervor, that people can do this. People are hungry for this. We need something that's beyond just focusing on physically staying safe for a time. They need a taste of recovery from day one to even be able to want to climb the uphill battle of being able to navigate the care systems, be able to navigate all the systems and processes to be able to do this. And so we developed Thrive, focused on the interpersonal theory of suicide, which I know most in this room are familiar with, this virtual room. And we looked at targeting sort of belongingness, perceived burdensomeness, and hopelessness about those conditions, along with self-hate. I could have added that to this graph, to be able to create recovery motivation. Our sense was, if people were able to start tasting and seeing and believing in what a different kind of life could be, whether that's getting their life back or helping them develop the life that they always wanted, that they weren't now sure they could be able to live, that it may help with both desire for suicide and also treatment initiation and engagement after discharge, because these clinical encounters are so short. You have a very, very short time to intervene with people. And so at the time we started down this road, I had been doing this kind of work already, and thankfully I had been building some programs, but they were different in dosage. And we'd done several preliminary studies, and I was working with Centerson at the time and brought the program there. We were able to get several grants in which we inserted this program into, with federal support, of course, to be able to look at interventions of this kind. And we had really, really good preliminary data, which I'll just share briefly. This slide just gives the demographic composition of 6 different cohorts that we saw between 2015 and 2025. Most of them are with adults and 2 were with youth. And this kind of crisis follow-up program using a Thrive approach saw individuals who were transitioning out of hospitals and emergency departments at the time. And we were using this approach. We counselors were the interventionists here, and we were really targeting people and calling them. And we tried a couple different iterations, but we found that calling worked the best. To be able to call people once a week from 4 to 6 weeks. We tested in a little bit different ways. And we found that we could, in a very short time, within 4 weeks, engage this programmatic target, perceived burdensomeness and thwarted belongingness, with kind of small to moderate, in some cases, larger effect sizes. And we found, which I could go into further, that the versions of the program that focused more on safety, people did not stay in those programs very long. When we were just doing safety sweeps, means restriction, safety planning, it's not a program they wanted to participate in very long. But when we were included the recovery, but we got statistically significant results. It's good, but we couldn't engage everyone in that program, or even most. And so what we learned was we had better program retention, better engagement, and actually even better outcomes when we were including the recovery elements, and also better changes in perceived burdensomeness and thwarted belongingness. These were our early outcomes on the recovery assessment scale. So we were seeing early, I mean, again, this is 4 weeks, so it's fast, right? Early changes in recovery in terms of goal and success orientation, personal confidence and hope, willingness to ask for help. And we're very excited by treatment initiation and lack of care readmission. So typically care initiation is, around 30% to 30 up to 40 in Tennessee. Where we were doing this research, it was 40 based on state average. We were seeing treatment initiation rates between 62 and 92%. And continued engagement in care and very, very low treatment readmission. And so we were so excited that we knew we could do a program like this in the community. And then lastly, I'll share we were also seeing changes in suicidal ideation, resolve plans and preparations, and self-efficacy to avoid suicidal action. So we're seeing these changes, altogether over 1,000 people delivered this program in the community. And we were excited to think about adapting it for crisis stabilization services, but we knew that elements needed to be different. And the biggest change there being we only had a single session. So, we tried. So can we have 2? Can we have 1.5? Can we do and just with the resources that the community has right now, they were really, I remember very intently when Adam says we could start with 1 and then see where we go from there. And we have iterated since then, but that's where we started. And so since then we have, I was able, thankfully, to get AFSP funding with Dr. Tony Pisani being the academic mentor on this study to study what we call Thrive-C and Crisis Stabilization Centers. And this is a version of this program that is a single session. And so it is a counseling intervention, this version of it. And I'm going to talk just a little bit about the components. It borrows elements and adapts elements also from narrative exposure therapy because we wanted this to be very trauma informed. And it also has good outcomes for suicidal people in some of their studies. And so in Thrive-C, we basically give people 4 different components and a very brief targeted intervention. The first component is that we create a restorative, suicide-specific and recovery-focused alliance with them. Our sense is that in the past, many interventions start with the provider or practitioner being relatively a blank slate. They're being assessed and reassessed in multiple different ways by multiple people. And we decided that we wanted this, although we would include elements of assessment, to start as a healing conversation. And with some techniques that may help lower the threshold for deep and honest disclosure. Our sense was we've got an hour, we've got to get there fast to this place of deep restorative trust to where we can really talk about what's going on. And so we use some specific techniques, in part from interpersonal process psychotherapy, to really set the tone differently. We tell the person who we are. We tell them our values. We tell them why we want to do suicide care. This is not just the 2 o'clock person that we're seeing. we're doing Thrive for a reason because we believe in suicide recovery and what that means for people. And we're also telling them our values in terms of repairing broken trust from past care experiences with counselors around suicide. We want to make it really clear that we not only value and want to understand their suicidal experiences and want them to be able to be safe from suicide, but we also know that for many people, safety by itself is not enough to be able to live or sustain life for any length of time. That recovery has to be the goal. Reducing suicidal suffering is non-negotiable, and that we want to be an aid in that, and that we don't want to focus only on safety, only on risk. And we found that that means the world to people in many, many cases, and we'll talk more about that. So we do have a really intentional experience in those first 10 minutes. And I tell my residents and other people, that we train in this for studies, this needs to feel like a different encounter than they have ever felt from any care experience they have ever had. And it needs to be memorable because they need to feel seen, heard, validated in a way that they never have before, especially around why they're there. And so we really get good feedback from our from our research participants about this component of it. And the most important piece of it, I should say, is that it has to be genuine. This is not scripted in the sense that every person says the same thing every time. We are very intentional in the training that it's personalized, deeply personalized to the provider, that's delivered to each unique person in a slightly unique way that's tailored to them. We also invite the person to tell the story of their suicide crisis. I think this is a pretty universal common factors component of every suicide-specific intervention and a very important one. And then invite them to create this autobiographical timeline. So you see at the bottom, this is an example of we call the Lifeline activity. And what we have them do is we have them in a very organized, tactical way tell their life story in terms of the difficult life events that have really defined, we call them defining life moments of who they are, how they see themselves, the world, and others, and also defining life moments that shaped them from a sense of joy, mastery, contributing, belonging with others, right? So you hear those themes. And then so we have them what we call lay the lifeline, and then engage them in a meaning-making activity to really start thinking about, given who you are, given what your story is teaching us about who you are, what you need in order to be able to live your life, and what you need to possibly go forward, to be able to go forward. We start really thinking about, when we look at the end of the lifeline and that coiled rope at the bottom that represents the life left to be lived, what has to change? And for many people, as we're learning, it's not tweaks, it's not small adjustments. They've already tried all those things. It's transformation, but they know what they need and they know what needs to happen. And many people are just stuck in being able to find the next step. So then lastly, help them create a meaningful living plan, which really puts together all of these components of what we've learned. And it's really an action plan. Okay. People ask a lot of questions about this. This is not a reasons for living plan. Reasons for living are things that you already have. Okay. This is not a, why my life already matters to plan. This is like, what do I need to start getting into my life anew or in new ways or back into my life to be able to live it? This is an action plan. And we create very targeted steps, specific strategies around values, strengths, things to keep you going when the going gets tough in terms of resiliency and hardiness. And so we really help people think about, this is your plan. And also we're going to be with you on that plan. So this intervention is unique in the sense that it is brief. It's appropriate for suicide. People have suicidal ideation and or attempts. There are some rapid suicide-specific and recovery engagement strategies, and it's narrative and trauma-focused and growth-informed. This is a brief picture of our meaningful living plan we use for this intervention. You kind of see several components there, and I can go into more about that if people have questions. We changed and iterated as we've learned. Okay, so in this is very early phase intervention development research, and so what you're going to see here really kind of focuses on that as apropos and should be for this stage of intervention development and testing. In this early preliminary study, we were really just starting to look at feasibility and acceptability of Thrive and crisis stabilization centers. with initially 30 people and then doing a randomized pilot clinical trial with 150, which we're still analyzing that data and hope to get that out very soon. Pretty excited. And so we have published this if people are interested in reading the paper. But basically we found in this setting that, people really felt like Thrive was, feasible, acceptable. The kind of mean age, we recruited 54 people for this study, and most people around the age of 38 years old, so slightly more males than biological females. A bit of diversity in our sample in terms of racial diversity. 70% were unemployed, 62% had a high school education or less, 70% had one or more suicide attempts, with the mean number of attempts being 2, and 69% in this sample were homeless or housing transient. So we've collected data from the guests, the study therapists, and stakeholders about the feasibility, acceptability, and implementation appropriateness of Thrive. It scored really well in terms of people's feedback. I thought it was really interesting that the external stakeholders rated it just slightly less than the people who were doing it, maybe because they were doing it, they just like, yeah, we do it every day. But still 80% is really strong. And we feel very excited about the possible translatability and scaling up and out in the future, after and if effectiveness should be demonstrated. Thrive had really great fidelity in terms of completion. We had good adherence, competency. Interestingly, the master's level therapists did not have better fidelity scores than the interns and trainees, which is good because these facilities get a lot of trainees that need to be able to do the intervention. And the URAP scores were really good. We actually added the URAP immediately before and after the intervention because we just wanted to make sure that there was nothing in the intervention that people had an adverse reaction to since it was new. But actually, it improved for everyone, just about 92% of guests, including suicidal ideation, which was really exciting to see. And and then one, it was neutral. I didn't know adverse study-related adverse effects or study-related adverse events from the DSMB that followed this study, which was really exciting to see. We also kind of start looking at signal and some of these kinds of things. So we asked them at the end of right before their discharge, if they knew what kind of behavioral interventions or treatment engagement they were willing to do. So you see that listed here. People were, eager who received Thrive to engage in lethal means restrictions, using their safety plans, which we do think are important, using their meaningful living plan to create recovery in their lives as much and as fast as possible. Adam often said, and so this is his language, I give him full credit, that the meaningful living plan teaches us why we want to stay safe. And the safety plan teaches us how to stay safe. And we think that teaching that with people hand in hand can have a lot of value and potentially may increase safety plan use, but that's another study for another day. Taking medication and going to outpatient therapy appointments, 91% said they were willing to do that. And following up on discharge recommendations. And then honestly, it's really important to say Thrive appears to be safe. We didn't have any study-related adverse events that were reported or cataloged here. And that's really meaningful because I think for a long time in suicidology, we have considered you must be and stay safe for a certain number of days or weeks or months to be able to then to get into recovery, right? Recovery comes later. Recovery comes after stabilization, after safety has been established. And I think that, this study is a first step, and it is a early first step. Let me kind of stay close to where the data is, but it's an early first step to say, maybe recovery can start at the beginning. Maybe from day one, many people, or at least certain people, are ready to talk about what do I really need to change in my life in order to live. And it could be that some people need to be able to do that before they're willing to stay safe. And those are people that we may not always treat. Sometimes if people are not ready yet to restrict access to lethal means, we don't give them suicide-specific psychotherapy. We kind of say, come back when you're ready. And so I think that this intervention, more research is needed, but may be engaging of certain people who are at a different stage of their recovery, who can definitely do this at that juncture. And we can share more about what we're learning about what that means after as well. So yes, 94% of the people receiving Thrive-C demonstrated readiness for recovery work at the end of external crisis. These are some of our quotes from our Thrive guests. I love that people are talking about the intervention helping them find joy, happiness, putting my care needs first. Past experiences in therapy have never made me feel this happy. It made me feel like there's worth and I'll be helping someone else. And then the last statement, I think I would go to therapy if it were more like this. And so when we think about treatment initiation and the value in that, we were excited to see some preliminary, and this is of course qualitative data, but we really care about that corrective emotional experience to say, sometimes therapy can really be what we need and healing. And for these people, at least, it's what seemed to be effective in these ways. Okay, and then lastly, I just wanted to shadow additional research is being done. I got some requests during this period to say, this is great, we want to do Thrive, and can our peers do it? And I'm like, I don't know. Like, we've not done it with peers before. We've not adapted it to peers, but peers are certainly experts in their own recovery. And we also had a group intervention that I was testing at the time at CSCs. And so I'm doing some preliminary work on. And so Dr. Tony Pisani and I have an R34 grant right now that we're working with Connections Health Solutions and Mental Health Cooperative to study a group-based intervention that's called the Belonging, Giving, and Recovery Group. And then the individual is followed up to 4 weeks in this study by a peer, and to kind of help them in putting their meaningful living plan into action. I have a lot of preliminary data. It's coming soon, I promise. But what I can share is that we went through a really awesome it's called a MADI process. It's a very specific implementation science process for treatment adaptation. And we did a lot of work with the peers and with the facility to think about what the role of the peer would be. And one of the things that we learned that fascinated me is that the peers did not want to do safety plan. They did not want to do the CSSRS in a routinized way. They said, that's clinical. I don't want to have to do that every person every time. And so what we did is we made some modifications to our Thrive follow-up program that we delivered before with counselors who felt that was part of their role, I'll put it that way, to then give people a menu of things that they could work on with the peer and the post-discharge follow-up. So I'll kind of leave those outcomes for another day. They're coming soon. I'll kind of respect the peer review process and all those things, but we're very excited about them. Both the feasibility, acceptability data, and of course, starting to look at early signal. So in terms of where we are in the process, I just want to give a big shout out for saying we should continue to honor and integrate individuals with lived experience into this work. I think that has made such a big difference in what we're doing. And again, to kind of stay close to the data, this is pre-intervention and kind of early pilot work. We do not yet have the, large outcomes from large effectiveness studies yet, but we are certainly working in that direction. And so I get requests all the time, can we start using Thrive? Can we bring it to our facility? And I think that speaks well of the enthusiasm people have. And also just out of respect, just really want to share, we don't know until we know, until we do the research. And so we hope to continue, to grow this work as we continue. So I really thank you all for your time and attention today. We're really excited by this and starting to rethink, I would say, including with my work at UAB, how do we start, if it's true that certain people or even most people can do recovery and want to start talking about that or integrating that into their work from day one, what does that mean? What does that mean about how we do all parts of the engagement and suicide, what we traditionally call suicide prevention work? What does it mean to engage people in ways that can honor both of those things and potentially at the same time? And even in my clinical practice at UAB, I would say this concept continues to be transformative in terms of rethinking and relooking at some of the fundamentals of how we do risk assessments, for example, how we engage people in treatment. And we just continue to be thankful for all of our individuals in research and in our daily practices that we have the honor to walk beside and with and for to be able to grow lives that they self-identify as thriving. And so thank you all so much for the chance to be here and talk about this.
Thank you so much. It's so exciting and so kind of fitting with the kind of culture of what we're trying to do, but also this, increasing move in our community toward crisis stabilization centers and what should we do. Let me throw it open to folks. Feel free to just jump off of mute and speak up, or use the chat to ask any questions or add any comments for Jennifer.
Hi there.
Go for it, Jennifer.
I'm Topher. I work for Harborview Behavioral Health Institute in Seattle. I am also a person with multiple suicide attempt survivor and have spent the better part of the last bulk of my career developing and implementing peer support programs in crisis settings and community mental health. And I am so excited about what you have presented. The the recovery approach and just you describing that first 10 minutes of the clinical interaction was very powerful for me. I worked for a while developing videos, a video library of people with lived experience with suicide as part of Jasper Health app. I worked for them for a while and spent a lot of time at the bedside showing people these videos. And in the formative development part of the practice, I was able to disclose that I was a suicide attempt survivor, and that immediate connection and the immediate sharing of deep personal experience is so powerful. And so I love how you're trying to get at that with other clinicians. And I'm really excited about the idea of how you might be utilizing peers more in this work. So anyway, if you ever want to have a conversation, I'd love to.
Oh, please. Yes, we will schedule something because I definitely appreciate your kind words. And that means so much to me. I feel it here when you say that. And interestingly, the more I've gotten a chance to work with peers, you're right, there is something very instant in the connection and the non-judgment, as we're hearing about being able to work with someone who has experiences like we do. And it's so funny, sometimes I spend more time retraining my counselors about how to approach this than I do peers. Peers get it. And it's like it's instantaneous almost, and in terms of that encounter. And there's a lot of value, I think, in both. I'll just share briefly, we're actually doing, my lab is leading a qualitative study to look at the mechanisms of change in terms of how peers hit those targets, at least in Thrive. Because what we decided on in this trial was we're going to agree on the outcome. Like, we know that you can hit this target. Here's some strategies that we tend to use in counseling, but this is not counseling. And so let's go hit this target together, and we're going to study how you do it. And the things that are coming out of that data set are amazing. Peers do this in a peer way that's not counseling, and are very, very effective in helping people not only stay safe from suicidal actions and behaviors, but really engage in their life in new ways. And so I believe that everyone has a role, and interdisciplinary teams are very valuable, but lots left to be learned about that uniqueness of peer support. And it's amazing what peers do. So thank you so much for sharing that with us.
Do you have any plans of looking at the model with other types of non-licensed behavioral health folks?
We have really considered that, and we welcome kind of ongoing dialogue about that. Because we have learned in our more recent research that individuals, paraprofessionals, can do elements of the model in their way, with great fidelity and preliminary data, good outcomes. We have started to wonder, are there other paraprofessionals who would be interested in this, who would perceive this as part of their role? And so we're really trying to think about that and excited about that, but certainly welcome ongoing dialogue with people who have ideas or site partners or, anything, collaborative research ideas, anything like that. So
thanks. And since nobody else is asking a question, is there information on the model online? I was just searching through and I found the paper and some other stuff. Is there, sort of like a resource website? How much of this is, available for viewing?
yeah, that's okay. So the biggest pieces right now are in the kind of the paper that we just published, and we've got a couple more coming in terms of on the adaptation with the belonging and giving group and the peer support follow-up. So most of it, I think we've intentionally held back a little bit. We get so many questions about Thrive and people ready to just like, it's been a push-pull because people are like, we don't have anything else. Like the existing interventions are too long or not recovery centered in the way we think they need to be to work. And it's like, like the practitioner in me is just like, it's evidence informed. It must be better. Maybe it's better than nothing. We don't know because we haven't researched it. And the other part of me is like, but we haven't done the research. So it's an ongoing push-pull that we haven't kind of put it out there into the world in that way on a website for that reason yet. So hopefully more to come, but thank you for asking.
Yeah, well, I mean, it's both. I love that it's the evidence informed, but it's also so positively focused, right? To have such a brief intervention that's such like a strengths based and like an engagement in that way is sounds
Yeah, absolutely. We can say anecdotally, I'll just offer that we anecdotally from the people who have been in these research studies and then talking with our practice partners, they are particularly encouraged that individuals that they felt like were not responsive to safety planning, that they were concerned that they might need to admit up to a higher level of care, that we have seen treatment response in a number of those individuals. And this is pilot research, but it's an encouraging thing to think about because some of the stories that they are sharing with us and that our patients are in the trials, we call them guests there, I should honor that word, they are guests. They are really sharing about that there are things about the intervention that may spark a motivation toward living that we're still working to understand that for people where they're not at a place given the pain and suffering that they feel to start there, to start with means restriction, to start with safety, it really makes sense that people are in different spaces in their journey. It's an inherent part of the suicidal experience to not want safety sometimes. But we are encouraged that, once receiving Thrive, some individuals in this intervention not only did not have to be admitted to a higher level of care, they were then able to readily, meaningfully engage in those other things that really do work, that really do help. So again, I love Adam's language. I give him full credit for that. Sometimes we have to know our why go through all the efforts to climb this big mountain and stay safe one more day to be able to do it. And we are excited that the intervention may, and other forms of it may touch on both of those in a hand-in-hand kind of way that, we typically reserve recovery for the end. It's like, let's stay safe, let's do people in safety, whether it's targeting the core drivers, getting, skills training for a life worth living, all very critically important. But at least in my clinic, the individuals that are not ready to do that from day one, then what do? Right? Traditional focus of care is to say, come back when you're ready, come back when you can, we're here. I think we're finding that a different approach works very, very well for people that we traditionally are not engaging in outpatient mental health care that deserve really good care. And so we're excited about that. Just from a clinical perspective with the people we have the privilege of serving. And our message at UAB is come as you are. Come as you are with any part that you're ready to change. We believe we can help you. We believe that we can be on the journey with you. And we believe it can be transformative in a way that people are in the own driver's seat of their lives.
I'm wondering when you're kind of thinking about this in the more clinic context, one of the things kind of coming from a DBT frame is like learning to live with the reality that this person might not make it and not trying to get into a control battle with them, which is, so difficult for a lot of clinicians because of the pressures on the clinician to have checked every box because otherwise they would be sort of considered not doing the right thing. And it's really, I think, driving this pressure towards safety planning and means counseling, et cetera, in a way that I think is now creating a really challenging balance against what patients actually want. And I'm kind of wondering how that sort of plays out when you are in a more traditional clinic environment. And we do a lot of work also with primary care and traditional specialty care environments where folks are very focused on Joint Commission or other related kind of guidelines. So I just wonder how you kind
Yeah.
of
Yeah,
kind of
absolutely.
navigate this? Because we're always trying to get the recovery piece in and up against this just kind of pressure that people are feeling.
Yeah, no, I very much empathize with that. You know, UAB is, of course, a Joint Commission accredited hospital and one of the largest in the nation. And so we're also feeling a lot of, having a lot of, I think, healthy conversations right now, because as we all know, screening, screening suicidal people at the point of contact is required, treatment is not. Um, and sometimes that creates a lot of additional screening and actions, even based on the safety protocol, that are either very, very difficult in health systems at a cost perspective and may or not be healing for the patient. You know, in terms of people coming in for a routine surgical procedure who have chronic lived experiences of suicide. Well, we can't do your surgery today. Your CSSRS is a 4. And they're like, I'm always a 4. I've been a 4 for 5 years. Yeah. Well, not until you've been evaluated and let's sit here for 3 hours. Well, now let's push your surgery for 3 months. Right. It's just, it's a challenge. And so I think that I'm a zero suicide person. I've worked in zero suicide for a long time, but I think it's really time to reevaluate, you know, with the current practices that we have today, what is it doing? We know that we have research coming out from zero suicide initiatives that suggests that a universal screening mandate may actually take away bandwidth for care on the treat side of things for people who need it most. We don't know today if that's overall helpful or harmful in terms of or neutral in terms of the population health outcomes or even within the health system. So in our system, what I will share is we've kind of tried to take a hard look at all of the zero suicide literature, even the things from my personal knowledge of what we did while I was at Centerstone. I was the lead evaluator for all of our zero suicide efforts for many years. And I think what we have found is that zero suicide has had amazing impact in terms of the national recognition, getting screening on the map, recognizing that we can make differences in health systems. But as an entire service package, it doesn't seem to be able to be implementable without costs, without trade-offs. And we may not get, and it can with, you know, studies and with individuals and systems who can do research, but not every hospital is an academic medical center, you know, and even at Centerstone, we struggle quite a bit with certain things. So I mean, I think taken together, once people get to us in our clinic, we try to give a very clear message about recovery. To say all the things that you've been through so far to get here, we get that. You know, all the things of like that you feel today with coming up and sharing this, we're concerned about sharing this with us. We welcome that conversation, but we do use some of the same validation techniques just because it's good clinical practice to be able to help people feel very safe and sharing their story and aligning on the recovery goal, and to say, even when we're using evidence-based practices, because we absolutely use DBT, CBT, you know, use CBT for suicide prevention, CAM psychotherapy. We want people to get into these great evidence-based practices as soon as they can. And for people who are not yet ready or eligible, given the program criteria, we say, then let's start recovery. It's very interesting that people have a very, very good experience with that. And we're excited that we can engage people on multiple fronts. And it's really changing a lot about how we do things at UAB in terms of not only using the best practices that we know today, because we should be doing those. It took a lot of years of research to create those things. Our patients deserve those. But to also to say, well, we have individuals that are not treatment responsive, please let's not kick them out the door. They deserve better. So we definitely have a spirit of show up as you are, and we will do everything we can to help you not only stay safe, but help you thrive.
That's great. Thank you so much. And I do really want to highlight the, both for you individually, Jennifer, other people you work with, and just that the idea that we can move forward with these recovery interventions and think about how to infuse them into our clinics, and in particular, we have our R03 small grant program open now, and thinking, you know, if you or people you work with can think of ways that we could be incorporating like a one session intervention, doing things that are small and practical, which our outpatient medical colleagues really need. in their settings, that we welcome applications. And I'll just put the link in there just to kind of put that out there for people who might be interested, because I think this is really, I think the tide is starting to turn on this, in terms of being able to have a perspective of people with lived experience and of recovery. And I'm really glad to have your voice out there, kind of pushing that forward, and particularly coming from such a deep experience of the models we've been using, such as zero suicide, and sort of what works well in that, and where the really are the holes that we are going to have to fill if it's going to work. So thank you so much for being here. Really appreciate it, and hope to have you back when you have more data to share and more opportunities for people to participate in and use the Thrive intervention.
Thank you all so much for having me. I have so much reverence for folks on this call and then also joining us, and very thankful that we're all on this journey together. We have to have reverence for all that's come before, but also say what's next. So
Yes, exactly. Thank you so much.